the right, that is a lesion of nummular eczema, or lichen simplex chronicus, or itching and scratching. So we want to treat them differently because the rash that's fungal is treated with antifungal medication like terbinafine or fluconazole, and the rash on the right is really emblematic of the atopic syndrome. So we treat that as we would treat any eczema. So fungal infections or tinea infections are really caused by 3 organisms, and many of us like to use the Woods lamp to diagnose that, but remember, only one species of the Woods lamp is fluorescens, and that's the Microsporum. So we can't use that as the definitive option, but usually most derm rashes clear pretty quickly with the right treatment plan. So if after a week or 10 days we're not doing better, then we need to go back and sort of rethink our diagnosis. So typically on non-hair-bearing areas, we can treat that topically. And on hair-bearing areas, because the epidermis goes so far down into the follicle, we treat that orally. Now, sometimes we see things on the rashes of the hands and feet. And back in the States, many people believe that rashes on the feet have to be athlete's foot or some sort of fungus. But on the palms and soles, we don't tend to see fungi very often. So we see rashes on the palms and soles often in the spectrum of atopic dermatitis as well as psoriasis. So again, when we see fungal rashes, the scale tends to be in the periphery, not centrally. And the itch of atopic dermatitis, as you all know, tends to be intractable. The itch is horrendous. The itch is changing the quality of life. And so we treat these as we would treat any atopic dermatitis with topical steroids and calcineurin inhibitors and IL-4 and IL-13 blocking agents. And now we have JAK inhibitors, which are part of that. But remember, scaling rashes require insight and thought and appropriate diagnostic techniques. And remember that dermatology is a disease of patterns and geography and body areas. So when we see a rash on the abdomen, we look at other areas. And here we see, I'm going to try this again. That was bad. The circle I have there is our scraping site, and the umbilicus, the belly button, is a very, very common space for scabies, sarcoptes. And keeping in mind the atopic patient is more prone to develop sarcoptes, fungus, virus like mollusca, and bacteria like impetigo. So if we have someone who develops sarcoptes, it's important that the entire family, the entire cohort be treated with medicines like elamite and permethrin, and we use those both, not either or. But again, when we look at patterns, we like to think of things that remind us of certain things. And this truncal rash, we might think of as tinea versicolor or pityriasis versicolor. But if you look at that pattern, it's not so confluent, and the patient's a bit older. So again, the circle is our biopsy site. And this patient has the exact same problem, that atypical patchy hypopigmentation, which is cutaneous T-cell lymphoma, which we call mycosis fungoides. And that can be quite serious. It starts as a small eczematous phase, then can be a patch stage or a plaque stage, it can become quite serious. And that, fortunately, it's a very slow-growing tumor, slow-growing malignant event. So that is why the 3-punch biopsy is something that I insist on all of our medical students, all of our residents, and physicians across specialties have a mastery of. Because a 3-punch can confirm your suspicions, and if your suspicions are just too wide, can help you narrow the focus. So many times people think of acne as just a adolescent hormonal situation, which is not a big deal. Although I think we're all aware of the stigma, the frustration, the shame associated with facial acne and even truncal acne. So fortunately, when we have such advances in acne management, we have isotretinoin, which is a disease-altering, life-changing disease. But you can see this person's cystic acne is horrendous. Horrendous. You can imagine trying to go to school, to swimming pool with this. But this patient now, the same patient, is post-Accutane and post his first CO2 laser. So we do some laser. This is his first CO2 laser post-acne. And his self-esteem, his self-image, his quality of life is improved because he's no longer embarrassed by going to the pool or going to the gym or participating in sports without wearing his shirt. One thing I'd like us all to keep in mind, that ulcers on the skin, particularly of the legs, are not a diagnosis, but they are a symptom. If you have a hole in your leg, we have to figure out why. Now granted, most commonly it is stasis dermatitis, but it could be diabetes, it could be trauma, it could be elder abuse, it could be necrobiosis, it could be collagen vascular disease, it could be a malignancy. So if a leg ulcer does not heal, it's incumbent on us to figure out why that ulcer is not healing. Now, scalp nodules are often thought of to be sebaceous cysts or abscesses, complications of diabetes, complications of picking and secondary bacterial infections. But this patient came in with a fairly large, rapid onset of scalp nodules, and in his patient history informed us he had previously had non-Hodgkin's lymphoma, which was treated with chemotherapeutics. However, 2.5 years later came back, and this is a recurrence of his non-Hodgkin's lymphoma. And when we did the biopsy, because we didn't think this looked like a sebaceous cyst, when you biopsy into a sebaceous cyst, you get an eruption of pus or purulent material or sac-like material. So here we got a rock-hard nodule from which we extracted material, clearly not a sebaceous cyst. So the legs tend to have certain unique things about them. And here we see on the leg, this is a blow-up of the same person, with this yellow-purple atrophy on the shin. So the first question we want to ask is this person diabetic? Because half of the people that have this syndrome of necrobiosis lipoidica, in the old days we called it NLD, necrobiosis lipoidica diabeticarum, but half of these people have diabetes, and they can ulcerate. And what happens to a patient with diabetes with an ulcer on their leg? They do not heal. And then they get infected, and then they have an amputation. So it's very important to track this problem beforehand and monitor their diabetes and get their A1C to an appropriate level so they do not continue to ulcerate. Topically, we like to use calcineurin inhibitors, topical JAK inhibitors. We can sometimes use topical steroids as well. Now, in this patient, in addition to coming to Vietnam, which as I mentioned I'm quite fond of, this patient on the left and the right are from Uganda in Southeast Africa, I'm sorry. And they both have tuberculosis and malaria. And the woman actually also has HIV as well. So when you think of the comorbidities of immunosuppression, that raises the stake of the likelihood of secondary bacterial, viral, fungal, and parasitic co-infection. So because the immune system is not 100% up to par like it should be, our immune systems don't have the ability to respond in the way that we typically might see bacterial, viral, fungal, and parasitic infections. So on the left we see Candida with the maceration, the wetness, the moistness, and on the right we think, well, is that also a groin rash? Is that also Candida? But no, notice how that is dry and somewhat lower than we would expect. So in the immunocompromised population, atopic dermatitis can appear differently, and the treatment is also augmentable because of the comorbidities of HIV, tuberculosis, and malaria. So on the left, we would treat that person with fluconazole, perhaps some clotrimazole, ketoconazole, but also something for prevention, like perhaps a wash, or I don't like to use powders because powder contains mica, and that's the primary contact irritant. And on the right of the patient with atopic dermatitis with those comorbidities, very likely they are malnourished. So we want to increase their immune status by appropriate nourishment, as well as the appropriate atopic measures like topical corticosteroids, moisturization, emollients, humectants, calcineurin inhibitors, topical JAK inhibitors, oral JAK inhibitors, and injectable biologics anti-IL-3 and 4 and 13 class. Here's an interesting rash, which you might see get a phone call about, a hypopigmented rash on the face, which is macular. And they both look about that descriptor, but they're classically different. In pigment of color, we often, especially in very humid areas, on the right, we see a very atypical thing that we normally see in North America, was tinea versicolor or pityriasis versicolor on the face. Not something we typically see. We notice it on the trunk, neck, and upper extremities. And the other picture, the picture on my left, is pityriasis alba, which is a subset of atopic dermatitis. Two vastly different animals with two different therapeutic regimens. The patient on the left you would treat as you would treat any atopic dermatitis patient. And again, on his face, you'd like to avoid topical steroids. And on the right, you would treat that as you would treat any other pityriform versicolor or actinium versicolor. I personally like fluconazole. You can pulse ketoconazole, but I don't want to use ketoconazole orally very much because of its idiosyncratic P450 reactions. So here's a little humor, I hope it translates well, but it's important that you always listen to your patient. But sometimes you have to ignore what the patient says, because this patient tells me he had a spider bite. And we sometimes joke that spider bites don't usually cause this. This is a very long situation, and you see this person has a lesion on his deltoid, which is asymmetric. A, asymmetric. B, the border is irregular. C, the color is multicolored. And D, it is bigger than a pencil eraser. And sometimes E, it is elevated. That's A, B, C, D, and E, and that's a melanoma until proven otherwise. Normally, I would like to excise the entire lesion at one time so we can get the appropriate Breslow level. But in this situation, it's just too big, so we did a biopsy. And sadly, the Breslow where I did it was 8.4. 8.4 Breslow, and that's very, very deep, very large, very old. So it's important to listen to our patients, selectively decide what the appropriate historical element is, and then treat appropriately. So this man went on to have a sentinel node biopsy, a lymph node dissection, and is currently on targeted therapy. We see, particularly in rural areas, both in areas like where I come from in Ohio, near Appalachia, if there's not good hygiene and cleansing, people are often subject to bacterial infections, and they ascribe much of their cutaneous rashes to bacterial or fungal or viral superinfections. So here we see a gentleman that has these pruritic nodules on the wrist, which he ascribed to spider bites and infection, when in fact he has the 4 Ps, the purple pruritic papules, which are polymorphic, look very, very different. And that, of course, is lichen planus, which you can certainly diagnose by eyesight or by a 3-punch. But there is a rare but an uncommon, not rare, association with hepatitis C. So I think it's not imprudent if you're going to see a patient with lichen planus to evaluate their hepatic status, and particularly hep C. Now, in a population that is often barefoot and that has exposure to nails and infection, the risk of nail infection is common. But I want to point out something to you. You see at the base of the proximal nail fold, my pointer doesn't work. There is some leakage or incontinence of that pigment. That is a name that's called Hutchinson's sign, and the pigment has leached from the nail into the proximal nail fold, or from the proximal nail fold into the nail. That is a very bad actor. And you can see the 2 red marks where we injected with lidocaine, reflected the proximal nail fold back, and did a biopsy to ascertain that this was in fact a subungual melanoma. Now, it is not that de novo a subungual melanoma is any more mortal than a regular melanoma. However, the delay in diagnosis of these is such that the morbidity and mortality tends to be elevated because it's a delayed diagnosis. What I also want to point out to you is look at the distal nail. There is distal nail plate elevation, and there is subungual debris. So guess what? The patient has a near fatal melanoma and also has nail fungus. So you can treat both, but I would encourage you to treat the melanoma more urgently. And there are very, very, very many ways to treat nail fungus. You can use any host of oral agents. I don't think topicals works very well. Laser therapy can be, you can fly to Boston, Dr. Michael will help you with that. But there are many, many options for nail fungus that are manageable. So this is a patient who's, gosh, we do lasers. My gosh, I didn't even think about this. This is a patient that came to us for management of her rosacea, and she was on rosacea for a long time, and then she had a biopsy. You can see the biopsy site dehisced of the right lower corner there, and she has pyoderma faciale, and so we treated her with Accutane. She had had laser before. One treatment did not care for it, and it was not covered by her insurance. but this is an ongoing, longer than 20-week course of therapy for her hydrogel facial. Little quiz. So here we have a patient, and the first thing I want you to notice is how hairy they are, how hirsute that person is. And he's wearing a hat to keep the sun off his face. He doesn't like the sun. And I asked him, how much does he drink? And in North America, when you ask someone how much they drink and they say, I have a beer a day, you multiply that by 10, because you know they're under-reporting. So, and we ask about his diet, and he likes meat, he likes hamburgers. So the most important test to do here for this patient is simply a CBC. And their hemoglobin is 55 or 60, or their hematocrit is 55 or 60. So the treatment is to eliminate the dietary influences of porphyria cutaneous tarda. And then we bring the hemoglobin down. And you have to talk to the lab people first, because you want to get the hemoglobin down to about 10. And if you send that person to the lab and say, let's do a phlebotomy down to about 10, well, then you get a call back saying, well, you're going to make that person anemic. You have to explain to the lab people that you want to make them pseudo-anemic to clear their porphyria. And this is not a rare condition. I'm not saying I run a porphyria clinic, but we have a fair share of people with porphyria. And the lesions that diagnose, besides the hirsutism, the photophobia, and the diet of meat and liquor, are these flaccid blisters, which people will often ascribe to, I was working on the car, or working on plumbing, and the trauma caused me to have these blisters on my arms. So you really don't need to treat the blisters. You need to get their hemoglobin and hematocrit down to normal to take care of that. So I know you have a very robust, we toured yesterday the hospital. Thank you very much for allowing us to see you and your patients and your wonderful Durham inpatient facility, and a lot of psoriatic patients. And we know that the top of the back of the sacrum is sort of a telltale sign for psoriasis. And that little area of blanching around the sacrum, or any inflammation of psoriasis, is called the Warnoff ring. So this gentleman has been treating with clobetasol forever to take care of his psoriasis. But guess what? This is the same patient, and look at his hands. He has manual onychomycosis. Very odd. Not unheard of, but very unusual. So this gentleman really has tinea corporis, caused from the tinea manum, which he auto-inoculated onto his back. So the treatment is not adalimumab or clobetasol, but the treatment is terbinafine or fluconazole or ketoconazole to treat the fungal infection. So here is one of my favorite patients. She works near me, and she was treated for a very long time with no success for her hand eczema. And she works in an office, and she uses her fingers all the time, and just miserable, with splits in the fingers. And they hurt when she washes, when she does laundry, when she cooks, when she works with paper. And she had been on prednisone, she had been on methotrexate, she had been on Imuran, azathioprine. She had been on adalimumab. But honestly, she had this crossover syndrome, this schema syndrome, psoriasis, eczema crossover. And here she is, after 1 week with itacitinib, which is an oral JAK inhibitor, after 1 week. She's very happy. If she lived here, she'd bring me pho, because she was so happy that her fingers were better. And dermatology is not just getting someone's numbers where they need to be, it's helping them return to their quality of life. And this person's quality of life has returned because her symptoms of pain are much better. Now, again, foot rashes. When you see rashes on the palms of the hands and the soles of the feet, they can be different animals. Things like erythemal deformity, psoriasis, AD, and secondary syphilis. Syphilis is not eradicated. We see syphilis in specific cohorts, and I think it's important when you see a rash on the palms and soles in the appropriate patient context to check the RPR, because treating primary syphilis early is so critically important. It's also important to understand a total history of what's been used before. In the States, we have what's called nursing homes or extended care facilities where elder patients go to live once they have comorbidities and can't live by themselves. And this patient was using using a cream for their ear by the nursing home. And the nursing home thought that they had developed an ulcer because of the tubing of the oxygen. And this was in fact a squamous cell carcinoma, will not do very well with topical antibiotic cream and required no surgery. I'd like to offer that atopic dermatitis has changed dramatically in the past 5 years. One of my personal heroes, Matt Zyrus, does quite a bit of research in the world of atopic dermatitis, and people no longer need to itch. We can eradicate AD in the appropriate patient. So this little baby, you can imagine that the baby's not sleeping, the mom and the dad are not sleeping. But also we have people who are compulsive scratchers and itchers. If that is the case, we have to understand why. John Koo at the University of San Francisco was really the father of compulsive excoriations. And we treat these people aggressively. Call the atopic dermatitis if that's the plan. Eliminate their abuse of crystal amphetamines, methamphetamines, if that's the case. Or treat their obsessive compulsive disorders, and their skin is really just a manifestation of their psychiatric disorder. I also want to mention that lymphedema is not a primary diagnosis. So on the patient on the left with the purple pants, huge elephantiasis, and if you look carefully, you notice there's only one leg, right? So I'm just a dermatologist, but I know we should have 2 legs, right? So why is the leg missing, right? And probably because the blood sugar is 300 and the A1C is 15. That's part of it. But the patient on the right also has lymphedema. His sugar's normal. And this patient is in Malawi, and they have filaria. So we have to understand what causes the filaria and how we eradicate that. But once that organism, once that worm eradicates the lymphatics, it's not going to get better. Now you can perform a public health service and explain to the community why that is there, but that person needs continual compression support and public health to help prevent the spread of filariasis. So this is a very frustrating disease, but if you look at it, it's red and round and got a little bit of central clearing. And invariably, many of our patients can open their bedroom drawer and find a bunch of tubes. They can find a tube of tretinoin, and a tube of 5-FU, and a tube of Metrogel, and almost certainly a tube of clobetasol, right? So they've been using everything at home on this. But what's not there? There's no scale. And remember, ringworms scale. That's where the culture, that's where the KOH. So if you have a rash that looks like fungus, that smells like fungus, that screams it's fungus, but doesn't get better with any antifungals, probably not fungus, right? So rather than us treat with a different azole, a different allylamine, or a different benzolamine, I think the better option is to take your 3-punch and look for granuloma annulare, which, by the way, is indistinguishable under the microscope from NLD. But in children, it's often on the fingers and toes and hands and feet and ankles and wrists. In the adult, it can be anywhere, and the adult can be quite frustrating. There's quite a bit of research going on at many, many centers for the use of biologic, particularly anti-IL-17s and JAK inhibitor, particularly the non-selective JAK1s and JAK2s, and the TYK2s in the world of GA management. That's far down the road because it's not usually that significant a problem, but there's certainly a cohort that does. In children, as I mentioned, hands and feet, fingers and toes, wrists and ankles, it is often reactionary, post-strep, post-surgical, post-stress. And almost always you can control that with topical steroids and occasionally a burst of oral anti-inflammatories. But almost invariably, the history is the patient comes in and says, I have a ringworm I can't clear up. And when you hear that, the back of your head is, I have GA. That's the thing to remember. We've seen lots of tattoo things here. I just want to make a comment about tattoos, that red tattoo ink is a very common sensitizer. Whether it's an allergen or a sensitizer or an activator, red tattoo, I have an entire lecture on tattoos. It's kind of fun to give, but in Vietnam I think it would be not very helpful. But red tattoo dye are very, very significant. But not just contact dermatitis. I think it's also important we rule out things like sarcoid or any other caviarizing disease this can be the signal of that. We've talked a lot about psoriasis, and you are all experts on psoriasis. I will tell you, and you all know, that psoriasis can be a debilitating scourge of life. You have the bad psoriasis, which embarrasses us. We have joint pain. People don't want to exercise because their joints hurt and they're embarrassed. They don't get exercise, so they sit at home in their chair and watch TV, and they munch on all the lovely things you have to eat here that are sweet. Vietnamese sweet tea, thank you very much. And their psoriasis is worse and worse and worse. So we can aggressively treat that with acetaminophen, methotrexate, cyclosporin. We have a very robust psoriasis clinic with anti-IL-17s, IL-23s, IL-12-23s, and TNF-alphas. I think it's important that we help our patients guttate psoriasis. Gutta is the Latin word for drop-like, and I think when people convert from general psoriasis to guttate psoriasis, we should figure out why that is. Perhaps an ASO titer, treat them with doxycycline, and aggressively treat their psoriasis. This is a rare but not so terribly uncommon thing, and people it's often mistreated with tinea versicolor, which is infectious. But this is someone who abuses their heating pad. And why I bring that up is if we abuse our computers. If I take my computer all day and sit my rest with it, full screen, you get the treatment, stop the heating pad, stop Hello? Brilliant. Thank you. Come on, thank you. My message to you, with all the things I could leave with today, is atopic dermatitis does not need to permanently affect the life of the family, of the sufferer of the disease. So much of AD is a disease of shame. What are you feeding your child? What are you washing the child with? You're smoking in the house. AD is a deficiency in the immune system where IL-4, IL-13, Th1, Th2 are all aberrant. And it's our opportunity to help those patients. We have JAK inhibitors and IL-4, IL-13s that are helpful for that. And you can see the atopic facies, and they are prone to, all of these children I'm going to show you have atopic dermatitis and something else. So this child has impetigo, that child has tinea faciei. This person has impetigo, but they have impetigo because their barrier function is not working. And when the barrier function does not work, bacteria, virus, fungus, and parasite gets in. So here she comes in, very unhappy, but notice the atopic facies she has on her eyes. And after 5 days of mupirocin, she's at least not terribly unhappy to see me. She's still grouchy, but not terribly unhappy. And see, again, we have bullous impetigo from atopy, from atopic dermatitis. And I cannot remember the last time I saw a young person to a prepubescent person who had mollusca, who also did not have atopic dermatitis. So most of the textbooks say, if you have mollusca, don't worry about it, it'll go away. Well, that may be true if you have one. But if you have 50 mollusca, mom, dad, cousin, teacher, all be very, very unhappy. In my experience, you treat the AD first, your immune system sort of reacts, and much of their mollusca go away as the immune system fights it away. Now, this doesn't mean I ignore the mollusca. I might take one or two with a Q-tip of liquid nitrogen or a dab of cantharidin. But again, assess the atopic situation. Here we have scabies, again, secondary to atopic dermatitis. Young athletes like to wrestle. So this young man took a scouring brush, wire brush, to scrub his face, thinking he could fool his dermatologist into thinking it's just an abrasion, let me wrestle. But this is herpes gladiatorum, a specific fungal rash due to wrestlers. And then they get angry at their physician because I won't give them a note to wrestle. So you get. The other thing I'm going to leave you with is the importance and the psychosocial trauma of hidradenitis, which for years we thought of a disease of abscesses and uncleanliness and obesity, and it is also a disease of blame. And what I want to show you about this picture is look at her left axilla. That is the pus that's draining from the hole in her armpit. So imagine you're coming to this meeting today to meet all these wonderful people, and you have to bring an extra bag of pads and deodorant and perfume and medicine, so you're not sitting next to a new friend and your pus drips on them. Okay? That's real. And so before, our options were steroids and spironolactone and isotretinoin and marsupialization. And this is a very poorly misunderstood disease. And now we have drugs that are very, very effective in terms of anti-TNF-alphas and IL-17s and perhaps maybe others. So this is no longer a disease that needs to be shamed. And just imagine, that was the first one I showed you was Hurley 1. This is Hurley 2. And again, this patient is demonstrative of the extra equipment you need to get through your day when you have draining abscesses in your armpit, and your pelvis, and your perineum. I think it's always aware that people don't often come to the doctor when they're dirty, and so this is not a rash of being dirty. This is acanthosis nigricans, and oftentimes in populations where there is a tolerance of obesity, this can be a sign of insulin resistance. So I think it's important to look globally at this situation and not just treat that, and to make sure you don't have acanthosis nigricans. Make sure you have that, not carp. We had the pleasure of seeing a few pemphigus patients yesterday, a very, very serious problem. We can sort of have the analogy that pemphigus will kill you, pemphigoid, the treatment will kill you. So it's important to diagnose which one's which. I want to make sure I'm going to move fast here because I don't want to take up too much time. I don't want Dr. trying to hook me off the stage here. But when we have people who tend to itch and they think they have scabies on the elbows, that's a very reasonable thing. But they only get the scabies after they eat delicious Vietnamese food or cake or bread or sandwiches. So again, your 3-punch biopsy is very, very critical because you can then diagnose them with their dermatitis herpetiformis, put them on the appropriate medicine like dapsone after negative G6PD, and really change your life. Although a gluten-free diet is very difficult. We had the pleasure of seeing some vasculitis yesterday. I want to speed up a little bit here. Rosacea versus SLE. Usually not a tough diagnosis, but I think it's important to be able to differentiate the two. 3 punches are very effective. And again, not everything that looks like a zit is acne. On this patient, the most important blood test you're going to order is the PCO workup. What's their serum insulin? What is their thyroid? What is their FH-LSH ratio? Do they have periods? Are they regular? Do they have hair loss and counterintuitive hirsutism? Are they obese? This is the syndrome, and of course, once this is eradicated, with the appropriate medications, can be treated very nicely. Continue to speed up here. Dermatomyositis. You miss it, it's very, very bad. People have weakness. But you ask lots of people, are you weak? The metric I like to use is, are you weak? Is can you get something from under your sink? If you're in the sink, in the kitchen and the sink is clogged, can you get up from a squatted position, or when Dr. Khan's doing yoga, flat-footed yoga, can you rise yourself, or do you need to have help hauling yourself up? That is the muscle weakness for dermatomyositis, and you see she has the heliotrope rash around her eyes and the Gaucher's papules on her fingers. Black skin on the face, particularly on the perinasal area and by the medial canthus, sarcoid until proven otherwise. We have the round rash that heralds the onset of other small red papular squamous lesions around it. The heralding of the big rash a few weeks later causes pityriasis, or it develops pityriasis rosea. And I like to always end with a little bit of humor, and I hope this translates well. It probably does not, but in case of fire, make sure you take the stairs.